Hello, everybody. Welcome to iCubed. This is the 24th episode, believe it or not. 2 years.
Wow.
Right.
Dr. Lee, you are a veteran of this.
Very good. That's right.
Nice.
I learned along the way, and it is definitely my labor of love. I want to welcome back my wonderful colleague, Dr. Fulton. He's been here twice before. We talked about the central cord syndrome, and we talked about the dental bleeding. So welcome back, Dr. Fulton.
It's good to be here. It's good to be with you, Dr. Lee.
Well, introduce yourself one more time.
Yeah, so Bill Fulton, community doctor. I grew up in Arizona, been at Banner Baywood off and on since 1994, which usually makes me the oldest person in the room.
Except
for Dr. Lee, who's got me by a month or two.
Yeah, so we are the old guard, right?
We're the old guard, yes.
Well, Dr. Fulton, I have worked with you for a long time, and you are absolutely the stellar example of a professional. In fact, on Webster's dictionary, if you look under professional, it should have your picture and your career right there.
Wow, I bet she tells that to everybody who comes on iCubed. So
no, you can listen to it.
If you too want to have that said, come on iCubed.
Very good. So this month, we're going to talk about two abdominal pains.
Okay.
These are not extraordinarily out of the ordinary cases, but they do have some important teaching points that I wanted to bring to the screencast and to especially the younger practitioners, because abdominal pain is bread and butter for us, right? We see it all the time, every day, and there's some subtleties to it, and I just want to bring out some points. So I want to talk about two cases, and we're going to go through them in fairly good detail just because I want us to kind of really soak in the cases, all right? So the first case, 62-year-old young, around here 62-year-old is young, but 62-year-old male, he's pretty healthy. He comes in with an acute onset of pretty severe mid-back and upper abdominal pain. At one point he said it was in the belly and radiated to the back, and another point he said it started in the back and radiated to the front. But he was in so much distress, I think that it was hard for him to keep the story straight. Okay.
Okay. Sounds good.
It started maybe an hour before he came in. He does have a history of GERD. He's on a PPI. He has been told in the past that he has gallstones, so that's one of the first things he said to us. He did have some drinks, a couple of them, before he came in. So I walk in the room, I'm looking at the chart, blood pressure is 168 over 107, the pulse is 71, his respirations are 21. I think somebody counted, actually. That's an odd number. And the temp is 36.3 orally, and his stats are 99%, so it's nothing really that.
Yeah, and for us, everybody's hypertensive that comes in. But again, that's important with vital signs. I think that's one of the things that's very important, especially when you get going fast.
Sure.
You've got a bunch of patients to see. It's easy to overlook abnormal vital signs. So one thing I'd say, let's always look at the vital signs.
I agree. That is great. So I walk in the room. His wife is at his bedside. He is standing over the sink, and he's leaning over. He's dry heaving, right? He's restlessly pacing. He's in pain. He's a little cool to touch. He's normal coloring. He's not like cyanotic or ashen or anything, but he's a little cool, and he's just really in a lot of pain, right? I can't really touch his belly. He's can't lie down. He's kind of pacing, but just a general exam of her belly, touching it. He's, tender is the tenderness is mostly in the upper part of the abdomen. So you get sort of a mental picture of what this looks like. Yeah. What now?
Well, first thing, the vital signs, they don't really help us, right? It's kind of, we don't get a lot of, although hypertension makes you think of vascular things, right? And there's lots of vascular things that can cause abdominal pain or mimic abdominal pain. He's 62, fairly healthy guy. When people are pacing around, that makes me think less about peritonitis, right? Usually peritonitis, like a perfed appy, you're not going to move because moving hurts. They'll talk about, hey, when my family member driving me in, I go over bumps, it hurt. So that makes less likely for this guy. Right.
Those are the same thoughts that I had too. I walk in, he looked almost kidney stone-like. That's the classic comparison, right?
Yeah.
If you have appendicitis, you don't want to move. If you have a kidney stone, you're moving around because you're restless. That's the classic dichotomy. Yeah. Well, he looked more like that kidney stones guy, but he was in a lot of pain. And the pain wasn't unilateral, so a kidney stone did not make any sense, right? So for me, I was thinking, well, this is the age of CAT scans and ultrasound. So I'm not going to do a CT, I'm going to do ultrasound. Which one first? Do I do them at the same time? What do you think?
Well, with our new grads, they can do the ultrasound right at bedside, right? Which is awesome for them. I'm an old guy. So I'm not going to be able to do an ultrasound. for me personally, if I have somebody that is in severe pain like this gentleman is, I'm going to go to CT.
Yeah.
I think CT is going to give me more information, so that's what I'm going to do.
I think that's great, actually. So I actually did not, even though I am a very enthusiastic bedside ultrasonographer, I guess, I did not do the bedside ultrasound. Part of it is because he was so restless and he was standing. He didn't want to lie down. So I ordered a CAT scan. I gave him some pain meds, and so that is the very beginning of that case. I wanted to give you a taste of that. Let's talk about the second case.
Let me just follow up on the pain medicine. You know, I remember back when we kind of started emergency medicine, back when we rode horses to the hospital. You know, pain medicine, we didn't do that, and now it's totally different.
Correct.
Get your patient comfortable, get them some pain medicine. So I like that you did that.
Right, and then in fact, there's an advantage of that because then you can examine them a bit better once they're a little bit more relaxed.
Exactly.
Yeah. So second case is a bit more interesting, actually. This was a couple of years ago. He's an 87-year-old guy. He comes in with upper abdominal pain. He's had for 5 days, okay? But it's gotten worse now, especially today. He had lunch and then the pain got worse and he vomited once. He also says he's been constipated for 5 days. Older guy has more history. Wife is at bedside, gives more history. So apparently he has some right shoulder pain. But the wife says, well, you know, he fell 3 weeks ago and I think that shoulder hurt from that. Wife also said, well, he's a healthy guy. He did 100 sit-ups the other day.
Love that. I wish I did 100 sit-ups.
And she said, well, maybe he overdid it. He also has a slight cough. He went to the urgent care about a week ago. He had a temp of 100.4. He was put on doxycycline. He followed up, just like good compliant elderly patients. He followed up with his PCP, who then thought his pain from his abdomen there was probably a rib contusion.
So my first thing, 87-year-old person, we got to think bad stuff, right? We need EKGs on this guy. We need to think worst case scenario on 87-year-old guy. And I love that his wife, and that's kind of that generation, right? The 87-year-old guy, they stormed Normandy. They're going to downplay everything. Right. So got to be really careful with an 87-year-old guy. And I don't know about the facilities that the docs are working in. I find that our oral temperatures aren't very accurate. So if I'm really worried, for example, if I have a patient who's tachycardic, I oftentimes, and I don't have any other source, I'll oftentimes do a rectal temperature. And it's amazing how often that rectal temperature will show a fever that the oral temperature did not.
So then past history on this 87-year-old gentleman, hypertension, hypercholesterolemia, he's got a pacemaker, he's hypothyroid. Actually not too bad considering our patient population. He's had a knee surgery, inguinal hernia repair, but no abdominal surgeries.
Okay.
So then he's on amlodipine, thyroid, lisinopril, simvastatin, and some supplements.
So pretty much the standard that we see. That's
very common for the geriatrics population. His vital signs on exam. Now I go into the room. He's laying on the bed. He's looking like he's uncomfortable, but looking, at least on the first blush, not as bad as the first patient. Blood pressure is 155/74. His pulse is 75. Respirations are 24, a little bit high. And his temp orally is 36.9 with a saturation of 95% on room air. So he looks pretty fit for an 87-year-old guy, and he's younger than he appears. He's a little bit heavy. He is in a moderate amount of distress. He's in pain. On exam, his chest wall is non-tender. His lungs are clear. His abdomen is rigid.
Okay.
He is guarding.
Okay.
Guarding. He's very, very tender, diffusely with rebound.
So, when I have that exam, I automatically start thinking we need general surgery.
Exactly.
And so I'm going to probably put a call out to general surgery right off the bat. And I think that's good. What your general surgeon doesn't want you to do is call him 5 minutes after he left the hospital, right?
Exactly.
So if you get that exam, call your general surgeon and say, hey, I'm not sure what's going on with this guy, but you're going to have to come see him. And that's going to make them appreciative, the general surgeon appreciative you did that. And it's also going to be very important for your patient.
So then what studies at this point, after you make the phone call? to your
Yeah,
general
well,
surgeon.
this one I'm thinking more intra-abdominal. 87-year-old guy, still going to do the EKG, chest X-ray,
right.
and I'm going to do a CT because the general surgeon is going to need a CT.
Yeah.
The days of them coming in and taking out the appendix, those are long gone. So you're going to have to do a CT on this guy.
And then you call the surgeon right away, which is exactly what I did. Because when I examined his belly, I was like, okay, this is a surgical abdomen. And so always the teaching has always been that if you have a surgical belly, you may not know exactly what's causing the surgical belly, call the general surgeon because they need to come in.
And the other thing is they may have some input for you on that guy. They may ask for something a little bit out of the ordinary that you're not thinking about.
That's right.
So always good to get them involved early.
Right. Excellent. So let's continue on the rest of the ER course. So the first guy, he's the guy who's pacing around. He's got upper abdominal pain. We get some labs back, and the CBC comes back. It's completely normal. His CMP chemical panel, chemistry panel, complete chemistry panel comes back pretty normal, right?
Things are looking good. Yeah.
His urine comes back pretty normal.
And as an ER physician, this is where you're pounding the table going, wow, somebody help me. I've got a guy who's really uncomfortable, and nothing's helping me.
So I'm medicating him. He is in a lot of pain, still in a lot of pain. In the meantime, somewhere in there, he gets a CAT scan, and the CAT scan comes back negative, essentially.
Right.
There's a hepatic steatosis, there's cholelithiasis on the CAT scan. So I send him over for the ultrasound because his labs all look great.
Yeah.
I don't have a diagnosis.
Yeah, and you're worried about this guy. This guy's really uncomfortable.
Right. So his ultrasound comes back. There's no gallstones on the ultrasound.
Love it.
It's a normal looking ultrasound. I go back to the patient. He's very uncomfortable. And I tell him, you know what? You don't have a gallstone at all on the ultrasound. That's the better study to show if you got gallstone disease. But you're in so much pain, I'm going to put you in the hospital.
Yeah, so for me, on these patients, which we all see these, as we know, I think it's about 50% of the time people have belly pain, you never know what the cause is.
That's exactly right.
So then with that group that you don't have any obvious answers for, then you have to make the clinical decision. Is this somebody that can go home, or is this somebody that we need to keep? 62-year-old guy who's in severe pain, that guy's not going home.
That's exactly
right. Yeah, this guy's staying.
And so we're lucky here that we have a observation unit, very, very appropriate for cases just like this, where I'm not comfortable as a physician sending the patient home, and they're not exactly an inpatient, so the observation unit works very well for patients like this. So he was placed in the observation unit because I talked to the surgeon. I told him this guy is in a lot of pain. I have a negative CAT scan, I have a negative ultrasound, but it could be ischemic bowel, it could be a whole host of things that's causing such severe pain. I'd like you to come and see him, right? So later that morning, this was a night shift, later that morning the surgeon sees the patient and takes the patient to the OR because of his pain. The diagnosis intraoperatively was acute gangrenous cholecystitis.
Wow. So a good take-home point on this patient is even though you didn't find anything, even though objectively we couldn't, we knew clinically something was wrong with this patient.
Something was wrong, yes.
And you didn't just stick him in the obs unit and hope your colleague, another ER physician, rounding on him to figure it out. You called the specialist.
That's right. Right, exactly. So then he did very well. But when I'm in the middle of evaluating someone who's in such extreme pain, all sorts of terrible things you're thinking about, right, in your head. And it was reassuring to me to follow up with him to see how well he did. The surgeon took the gallbladder out and he did fine, and he was discharged the next day.
Awesome.
Yeah.
Another save for Dr. Lee. That's why she's doing iCubed. She's very smart.
So truly it was an observation stay for acute gangrenous cholecystitis.
Awesome.
Yeah.
With everything being normal on him.
So what I found as I was researching this case, I found interesting that sometime later that day, after he went to the OR, there was an addendum on the ultrasound. The addendum said there was layering of gallstones, and so the original ultrasound said no gallstones, and the second, the addendum, which is the morning radiologist, put in that they were layering, and just showing in the ultrasound image that what they meant by the layering of gallstones along this bottom of the gallbladder.
Awesome.
Yeah. All right, case number 2. This is even more fascinating. So case number 2, remember he's an 87-year-old gentleman. He's in a lot of pain.
He's got the surgical abdomen.
Yes,
You've called the surgeon.
Exactly. He's got a rigid belly.
Yep.
So for him, guess what I did? I did the bedside ultrasound because he had a rigid belly. And I thought to myself, he's got free fluid or something in there, right?
Nice.
My reading on the chart was this. There's free fluid, which is perihepatic, and possibly some in the Morrison's pouch with perisplenic fluid, and I was unable to visualize the bladder. So this guy was in so much pain, I really couldn't press his belly really hard to see. But as soon as I put the probe on his belly, I can see free fluid around the liver. Okay. And so that already tipped me off. I said, he's perforated, something, right?
Right.
Because he's got free fluid. But I called the surgeon, and he goes, I need more studies. So he wanted me to order another CAT scan with contrast this time, and then an ultrasound after that. So while this is going on, I'm going off shift, but the labs come back, and again, here are the labs. CBC is fine.
Right, yeah, normal white count.
The CMP is fine.
Yep.
The urine is fine. Lactate is fine. But this
so we should send this guy home. Send him home. I mean, the labs are fine.
Yeah, exactly.
Send this guy home, right?
This guy is sick. So then I love CAT scans. I love looking at them. Do you look at your CAT scans?
Not as much as you do.
Yeah, I love looking at them. So, because I'm trying to correlate with what I'm seeing clinically or the bedside ultrasound and correlate that with what the radiologist is looking at. Because the radiologist said there was ascites on this man's on this man's CAT scan, but it makes no sense because this guy has no liver disease. Right. So it's not ascites. It's either blood or pus or something, right?
Right.
But I look at the scan and I'm looking and seeing what what the radiologist is seeing. There's a lot of fluid around the liver, and you can see sort of a shadow of darkness right here. See that? Right. That's fluid right around the liver, and there's fluid around the spleen on this side. So I question that diagnosis of the CAT scan. I mean, the radiologist calling a ascites because I know it's not. It doesn't make any sense. So the CAT scan does show signs of possibly cholecystitis. The CT reading says mildly hydropic gallbladder, demonstrating the suggestion of wall thickening. And so CAT scan was radiologist recommended an ultrasound, which we did. So the ultrasound comes back. This was a later evening kind of a case. The ultrasound comes back and says there's sludge, there's gallbladder wall thickening, and ultrasound is suspicious for acute cholecystitis. All right. So I'm talking to the surgeon. I talked to him right off the bat, like you said, right off the beginning. It's a surgical belly. Surgeon wants more studies. He wanted a CAT scan with contrast. He wanted the ultrasound. And I'm thinking to myself, well, don't they usually take these guys to the OR?
That's what we were always taught in medical school, right?
Yeah. So anyway, the surgeon did not take the patient to the OR right away that night. The next morning, the surgeon sees the patient is still having abdominal pain. So the surgeon orders a HIDA scan.
Okay.
And the HIDA scan was negative.
Okay.
Interesting, right?
Yeah.
Then the surgeon takes the patient to the OR finally that morning or later that day because the patient's pain was persistent and the lactate had increased from the normal 1.5 to 2.3 to 2.8. So for the surgeon, somehow that triggered this desire or this decision to go to the OR. The surgical note, fascinating, I love this. The surgeon says, I saw an inflamed gallbladder that was adherent to the anterior abdominal wall laterally, and when this was peeled down, there was a hole in the gallbladder with bile spillage.
Ouch.
So that liquid that was called ascites was bile.
Wow.
And it was trapped up in the liver like that. And in fact, it probably leaked around to the other side to the around the spleen. All that bile, all that liquid was bile.
So when I saw that initial reading, I'll do sometimes with radiologists, if I like to call, they don't have any clinical background, right?
Exactly.
So if you have the opportunity, it's nice to call them because sometimes they'll say, "Hey, Bill, that's right. Maybe this is whatever we're thinking about." Right. So I like to pick the phone up. I'm one of those guys. I don't just accept their readings sometimes. They're awesome. Obviously, they're better at reading CTs and ultrasounds than we are, but if their reading's not really consistent with your patient, I like to call them and chat with them.
I think that's really a good piece of advice, a really wise piece of advice, because I've done that throughout my career as well, because the reading doesn't correlate with the clinical picture, and I have them clarify it. Or if I look at the image and I see something, and there have been a few times where I see something that the radiologist did not, and they'll have to put an addendum. They'll go, oh yeah, you're right, and then they'll have to put an addendum to it, you know. So, you know, with my iCubed cases, my iCubed episodes, I have 2 learning focuses, right? So the first one is lab deception.
Here, here, here.
So these guys, the gangrenous gallbladder man had a perfectly normal CBC, right? The perfect gallbladder man had a perfectly normal CBC. And so I have to do this. You know Amo too, right?
Oh, he's awesome. Love him. Awesome teacher.
Iconic EM educator. One of my favorite quotes from him is this.
The white count is the last refuge of the intellectually destitute.
Yeah, amen to that. Amen to that, Dr. Matu.
So true. And it's not just the CBC. If you look at these cases, the CMP, right? The gangrenous gallbladder had a perfectly normal CMP, almost perfectly normal. Same thing with the perf gallbladder. So it's lab deception. We have to put that in the context of the real patient. Right?
Which is important in today's world that we all work in, where you're having individuals who aren't medical people make decisions on where we put patients.
Right.
These are patients that they might have said send home, right? Even though clinically there's no way you're sending either one of these patients home.
Right. We have to remember we're taking care of a live human being. There's 7.7 billion very individual human beings on this earth. So every single patient you have to approach as if they're a different snowflake than the next snowflake, because all the snowflakes are different. Then learning focus number 2, I'm going to have to do this because I'm a POCUS evangelist. So even though I couldn't keep images on this one, I think it's a starting point to just talk about POCUS. I really find that it's a technology that it's an extension of our physical exam, and it's appropriate for emergency physicians who want rapid answers, bedside answers, instead of waiting for 3 hours down the road. So I just wanted to show a couple of things that a couple of these images I've gotten in the past few months to demonstrate what utility there is. So this one was just within the past month, a retinal tear, detachment. Look at that thing.
Wow.
Yeah. And then just last week.
Wow.
So this gentleman bled into his pericardial sac.
And you were able to get both of these?
I was able to get that image.
Wow, that's awesome.
This one is free fluid around the liver. This is a kidney here, and then the liver right here, and the tip of the liver. This is Morrison's pouch right there.
Yeah, one of the things you hear all the time is game changer. Mm-hmm. Bedside ultrasound's a game changer.
Absolutely, you're absolutely right.
Game changer.
This was just a transvaginal ultrasound. Sometimes what I do is just at least get a quick sort of fetal heart tones that way, and it reassures the mom.
Yeah.
Yep. And then this was merely a still image of a asymptomatic AAA, and on the side is the centimeter mark. So this AAA is about 11 centimeters.
That's big, doctor. That's big.
Well, very good. Dr. Fulton, thank you so much for joining me. Did you learn anything in this?
I always learn. I learn just working with you, Dr. Lee. I just enjoy working with you. And yeah, these are great cases.
Yeah.
Great cases.
So very, very sort of frequent cases, gallbladder disease, but we just have to take away from this, remember to correlate your physical exam with what you're seeing radiologically or by the labs, right?
I totally agree.
Absolutely.
Awesome.
Well,
awesome job.
Thank you, everybody, for watching, and thank you for your support. Please come up and say hi to me whenever you see me at a conference, and I hope that you learned something this time, as I hope every single time I bring cases to the screencast. So we'll see you soon. Bye-bye.
Bye-bye. Have a great day.
Bye.